Okay, guys. So I'm going to be talking about congenital heart diseases. So, okay, so this is kind of like a long topic, and there are a lot of diseases that you need to know, but some of them are more important. So try focusing on them, understanding them well, and then you can know the others and just know kind of like an introduction and some of the complications of those diseases. So obviously, etiology is the most important thing. You need to know the etiology. So they can be idiopathic, they can be genetic, viral infections, or maternal risk factors can be present. Now, when we're talking about a congenital heart defect, most common childhood diseases occurring from third to the eighth gestational week. So normally these kind of congenital heart defects are occurring like third to eighth gestational week, and we are actually classifying these diseases according to the blood flow. And that's why there's a left to right shunt, right to left shunt, or it can be obstructive. Now, the congenital heart disease can be acyanotic or can be cyanotic. Acyanotic has a better prognosis. So left to right shunting is usually acyanotic. However, we say that it becomes cyanotic, it later becomes cyanotic. Then we have right to left shunt, which is usually cyanotic and obstructive, which can be cyanotic or acyanotic. So let's start with the left to right shunt. Now, as I said that it is late cyanosis or blue kids, the reason is because of the Eisenmenger syndrome. So basically what happens is that we know that normally the left ventricle has a higher pressure, the right ventricle has a lower pressure. So what would we expect? That if there's a ventricular septal defect, for example, the blood would flow from the left ventricle into the right ventricle. But what if I told you that after some time, the right ventricle has a higher pressure? So we would expect that the blood would start to flow from the right ventricle into the left ventricle. But why does this occur? Because obviously there's so much excess volume that is moving into the right ventricle that it causes pulmonary hypertension. When there's pulmonary hypertension, the right vent the, and it leads to right ventricular hypertrophy. Now we know that the left ventricle has a higher pressure because of the muscular structure that is present over there, and that helps it to pump, right? But in the case that there is hypertrophy in the right ventricle, and the muscles within the right ventricle are becoming thicker, what happens? The pressure within the right ventricle increases so much that it's higher than the left ventricle, and the blood starts to flow in the opposite direction, and that's called Eisenmenger syndrome. Okay, so if you see this word anywhere, that is what it means. Now, that's why in left to right shunt, because it is not direct, it leads to late cyanosis. But on the other hand, when I talked about right to left shunt, I said that it causes cyanosis directly. Okay. So let's talk about the left to right shunt. Now we basically talk about four diseases over here: atrial septal defect, ventricular septal defect, patent ductus arteriosus, and atrioventricular defect. Now, initially, when we're talking about the frequency, ventricular septal defect is the most common one. Then we have atrial septal defect, and then we have patent ductus arteriosus. You can know atrioventricular defect as well. Just know what it is, what happens. But the three main ones are ventricular SD, atrial SD, and patent DA. So let's talk about ventricular septal defect. Um, Now, in this case, obviously, we know that there's an incomplete closure of the ventricles. Most commonly, it is occurring within the membranous region and 90% of the time, but it can also be infundibular VSD or it can be muscular VSD. Now, it can either be small or it can be large. If it's small, then normally it would be asymptomatic and it can induce like these endocardial jet lesions, which means that there's a high risk of infection in those areas. Whereas when there's a large ventricular septal defect, it leads to massive amount of blood into the lungs, leading to pulmonary hypertension and right ventricular hypertrophy, like I mentioned before. And what does it lead to? Eisenmenger syndrome. And these are the ones that I mentioned over here, basically the complications. So we can see that there's late cyanosis, there's clubbing, there's polycythemia, and there can also be heart failure, obviously, because of the overload. And then we have obstructive pulmonary vascular disease. Because there's a long-standing pulmonary hypertension, it can basically lead to irreversible endothelial cell fibrosis. So these are the complications that you need to remember. Now let's move on to atrial septal defect. Now in atrial septal defect, this is basically a defect in the septa between the atria between the atria, obviously. And in this case, it is during development, which results in a direct communication. Now, here we basically talk about septum secundum, which is the most common. The septum secundum doesn't really grow completely, which leaves a hole. On the other hand, we also have septum primum failure, which mainly occurs during Down syndrome. So, people who have Down syndrome are most commonly they can have this, septum secundum, and can lead to atrial septal defect. Now, do not confuse atrial septal defect with patent foramen ovale. Patent foramen ovale is a problem with the fusion of the primary secondary septa. It is not ASD. Now, the complication in this case would be if we have a DVT, for example, and it passes into the left chamber at a paradoxical emboli, basically, and it reaches the brain. Obviously, there's a risk of a stroke, right? And the same complication is also present in the case of atrial septal defect. Then the second one is Eisenmenger syndrome, where again, obviously, it's the same that I've explained previously. Also, there is pulmonary hypertension in this case. Then we have atrial fibrillation, and in atrial fibrillation is due to the atrial hypertrophy that is occurring because of the increased pressure. So it's trying to adapt to that increased pressure, and it may even lead to right bundle branch block. Um, and this is due to the long-term right ventricular dilation. Okay, the next one is patent ductus arteriosus. So when we're talking about a patent ductus arteriosus, we know that this is basically the failure of the ductus arterius to close. And this can lead to a direct communication between our aorta, between the aorta and the pulmonary artery. So in this case, why does this latency basically occur? And this is due to the prostaglandin E, high prostaglandin E, and low oxygen tension. And these now patent ductus arteriosus can be linked to three major things. One is congenital rubella. Second is the tetralogy of Fallot, which I'll be explaining later, and prematurity. Now, the most important thing that you need to remember in patent ductus arteriosus is that it can lead to cyanosis of the lower extremities only. Because the patent ductus arteriosus is present after the branches of the aortic arch, which is supplying our upper limbs, our brain, our face, all of that is being supplied by those branches that are coming out of the aorta. But when we're talking about patent ductus arteriosus, what it does is the blood from the pulmonary artery, which is deoxygenated, will enter the aorta after those branches, and then where does the blood go? Into the abdominal aorta, right? So it goes to the lower limbs, and eventually what happens is that there's a mixture of this deoxygenated oxygenated blood leading to cyanosis within the lower limbs only. So this is the most important point. Now let's move on to our right to left shunt. Now, when we're talking about right to left shunt, there's early cyanosis. Why? Because in this case, we don't need Eisenmenger syndrome. This is already a right to left shunt, right? Is not like in left to right shunt, which is then converted into a right to left shunt. This is directly deoxygenated blood going into the where we have the presence of oxygenated blood. Now, in this case, there are two very important, we can say, pathologies that you need to know. Obviously, transposition of the great vessels and tetralogy of Fallot are extremely important. The rest, I would say, know about them, know what they are, and mention them if it is required, and know about the complications or what they can look like, right? So first of all, let's talk about the tetralogy of Fallot. Now, tetralogy of Fallot is the number one cause of cyanotic heart disease, and it's caused by the anterosuperior displacement of the infundibular septum, leading to a blue baby syndrome. Now, it basically has a classical tetrad, which you definitely need to know. The first, and you can basically use the mnemonic PROV in this case. So first we have the pulmonary stenosis, which is important for the prognosis, okay? There's a small obstruction which lowers the pressure in the right ventricle otherwise goes and mixes with aortic blood because of the ventricular septal defect. Okay, so what will happen? If there is an obstruction, there is pulmonary stenosis. Okay, the the heart is cannot put enough pressure to actually move the blood through that pulmonary stenosis. And in tetralogy of Fallot, we have the presence of a ventricular septal defect. So the blood, instead of going through that pulmonary, we can say the pulmonary stenosis, it prefers going through that ventricular septal defect. Okay, now stenosis worsen with growth, the opening doesn't grow, and the patent ductus arteriosus in this case would actually be helpful for the patient, right? Next, we can talk about the right ventricular hypertrophy. Now, in the case of tetralogy of Fallot, there will be presence of right ventricular hypertrophy. In this case, it creates a boot-shaped heart, okay? A boot-shaped heart on the X-ray as the right ventricular hypertrophy rises up the left ventricle. Okay, and um, so this is basically what we're seeing. Because of that stenosis that is present, the right ventricle needs more pressure to pump it, and that's why we can see this right ventricular hypertrophy in this case. Then we have the overriding of the aorta. So overriding of the aorta. Now normally the aorta is actually coming from the left atrium. It comes over the left atrium, okay, and gets the blood from the ventricle, right? Like you can see in the picture over here, right? It's over the left ventricle, on the, yeah, left atrium, I'm sorry, left atrium. But in the case of tetralogy of Fallot, what happens is that the aorta overrides and it takes blood directly from here, from the ventricular septal defect that is present. So think about it. We're getting, the aorta takes blood not only from the left ventricle, but it's taking blood from the right ventricle as well. Okay, and yeah, then we can talk about the ventricular septal defect, which I already talked about, right? So again, this is leading to a cyanotic spell. The patient cannot, cyanosis will always increase with exercise, right? Because obviously the heart will try to pump harder. There's peripheral dilation, rest resistance. Blood chooses to go through the aorta and not through that pulmonary stenosis. Okay, it will not want to go through the pulmonary stenosis, it just goes through the aorta because of the ventricular septal defect that is present. Now, squatting, however, can improve the cyanosis because as resistance after the aorta increases, so the blood actually has to go through that pulmonary stenosis instead. Now, there's a fifth thing that is also present that you can talk about, but in the tetralogy of Fallot, normally we just talk about this tetrad. So just know it in case they ask you about it. There's a TAPVR, which is total anomalous pulmonary venous return. So in this case, the pulmonary vein drains into the right heart circulation. And in this case, the atrial septal defect and the patent ductus arteriosus can actually allow the right to left shunting to maintain the cardiac output. So this is basically our tetralogy of Fallot. Now let's move on to transposition of great vessels. Now this is very, very logical. In this case, what happens is that there's a switching of the pulmonary artery. So the pulmonary artery, which is now into the left ventricle, right? And the aorta moves into the right ventricle. So that basically the great vessels will just switch. Now, when this switching occurs, normally, all our entire circulation is basically one. The deoxygenated blood converted into oxygenated blood goes into our body, which again gets deoxygenated, right? But in the case of transposition of great vessels, there are now two independent circulations being formed. Okay, and this disease is linked to maternal diabetes. This is very, very important. You need to know that transposition of great vessels can be seen in maternal diabetes. Okay. Now, this can lead to right ventricular hypertrophy and left ventricular atrophy. Why? Think about it. The aorta is moving into the right ventricle, and we need a lot of pressure to move blood into the aorta. Now, the right ventricle does not have the capacity, that pressure to build that pressure to push it. So what will our heart do? Hypertrophy. So right ventricular hypertrophy will occur, and that will, increase pressure and allow the right ventricle to pump blood. And then we have the left ventricular, I said, atrophy, because the left ventricle is suited to create high pressures, but now it's working with the pulmonary artery, so it doesn't need that much pressure, and so it goes under atrophy. Now, the baby in this case will only survive if there is another shunt that is present. Why? Because we want the mixing of those circulations, right? So, in this case, the baby has a ventricular septal defect, an atrial septal defect, or a patent ductus arteriosus that would really be helpful, right? That allows the mixing of the oxygenated blood. Okay, now I'll be talking about some of the other ones that are also you can talk about, just know what they are. So let's start with truncus arteriosus. Truncus arteriosus is basically when there's a failure to divide into a pulmonary trunk and the aorta. Okay, this leads to a single large vessel arising from both the ventricles. So the deoxygenated blood from the right ventricle is mixing with the oxygenated blood from the left ventricle before the pulmonary and aortic circulations will separate. Eventually they will separate, but initially there's just a mixture of both of them. Like over here you can see it. There's a mixture of both of them. The we can say the septum didn't develop, the we can say that the separation didn't develop between them, and this can basically lead to a massive blood flow into the blood, causing pulmonary hypertension and leading to chronic heart failure. Okay, next we can talk about the tricuspid atresia. Okay, now a tricuspid atresia is basically when the tricuspid valve orifice fails to develop, and this results in absence of communication between the right atrium and the right ventricle. So missing tricuspid valve. There's no tricuspid valve that is present over here. So there's no communication between them. Okay. Now, leads to right ventricular hypoplasia, which leads to atrial septal defect. And so the deoxygenated blood flows directly from the right atrium into the left atrium. And obviously, this can lead to cyanosis. This is logical. Look, so basically, what happens is that there is no tricuspid valve. So the right atrium now, the blood that is coming from our inferior and superior vena cava will basically from the right atrium go directly into the left atrium, and from the left atrium it will go into our body, leading to cyanosis. Okay, easy. So that is basically some of the diseases that you need to know. So total, I already mentioned the total anomalous pulmonary venous return. So you can know this, but if you mention, I think these four, it would be good enough. So now let's go on to the last part. I know this is a lot, but like you really need to know all of them, at least know their names. I would say that it's better to know what they are because they can ask you about it. So let's talk about obstructive, which is the last part now. So in this case, we talk about three diseases. Okay, we talk about aortic coarctation, we talk about left ventricular outflow obstruction and right ventricular outflow obstruction. Okay, so let's talk about aorta coarctation. Coarctation basically means narrowing. Okay, now there can be two types. We can have infantile or we can have adult. Now, in infantile, what happens is that the aorta narrowing is actually proximal, like you can see, it's proximal before the ductus arteriosus, the patent ductus arteriosus. They are related, okay? If there's a patent ductus arteriosus, normally it's related to the aortic coarctation. Thus, after the narrowing, the blood shunts from the pulmonary artery along the patent ductus arteriosus into the aorta. Okay, and this is after the coarctation, right? So this basically leads to again lower body stenosis, like I mentioned previously. It'll lead to right ventricular hypertrophy. Patent ductus arteriosus keeps the circulation going, right? So these are some of the effects of having this kind of, we can say, infantile type, right? these are, I've already mentioned the we can say the complications, and complications are really very important, so remember them. Then we have adult type. Now in the adult type, what happens is that the aorta narrowing is distal to the um is distal to the ligamentum arteriosum. When there's hypertension, so this leads to hypertension in the upper extremities and hypotension in the lower extremities. Okay, and this can, instead of right ventricular hypertrophy, we would see a left ventricular hypertrophy. Okay, why is there upper limb, we can say upper extremities hypertension? Because the blood, when the blood is being pumped by the heart, there is no patent ductus arteriosus to let the blood move here, right? So what happens is that there's a stenosis, or we can say that there's a coarctation or narrowing over here. So the blood is just going into these, we can say, divisions, these, we can say, branches of the aortic um of the aorta, right? So that's why there's a higher, we can say, pressure in the upper extremity, but there would be a lower pressure within the lower extremities, right? Decrease, there'll be hypotension in the lower extremities because the blood is forcefully being pumped in these branches, and very little blood is actually reaching our, we can say, lower extremities, leading to hypotension. Now, very logical that obviously if there is a narrowing over here, the heart has to pump much harder. What part of the heart? The left ventricle. So where would we see hypertrophy? There would be left ventricular hypertrophy. And in this case, it normally linked to a bicuspid aortic valve. And so this leads to rib notching. This is what you can see in the X-ray. Okay. So, so in these babies, we would see that they would be under underdeveloped lower limbs, claudication, hypertension can be seen because the RAAS is activated by the kidneys, right? Headache, dizziness, and even berry aneurysms. Why would they have berry aneurysm? Because so much blood is being pumped into the brain that it basically leads to the formation of a berry aneurysm. Okay. So this is basically what you need to know for the aorta coarctation. Now we can talk about left ventricular outflow obstruction. Now, why would we have a left ventricular outflow obstruction? It'll be due to some kind of aortic stenosis or atresia. Normally, it can be valvular stenosis, which is hypoplastic, or it can be hypoplastic, or it can be very thick, or it can be subvalvular stenosis in which there's a thickened endocardial tissue. Please remember that here we're talking about thickening of the endocardial tissue, not the muscles. Okay. Then we have supravalvular stenosis, which is the areas of dysplasia blocking the flow. In this case, we say that they shouldn't exercise, they can't exercise because of this, the problem with the pumps. If they do, there'll be too much pressure and it can actually lead to heart failure. Then we have right ventricular outflow obstruction. Now in this case, we would expect pulmonary stenosis or atresia. This is normally linked to atrial septal defect or patent ductus arteriosus, like I've mentioned before. Again, it can be valvular, subvalvular, or can be supravalvular, like we have mentioned before. Now, one thing I want you to remember is that when there is an outflow obstructive case, if it is a valvular problem, normally what happens is that right after the valve, there will be an aortic or pulmonary aneurysm that can appear. Okay, so that is something that you can mention it as well. It would be really good for you. And yeah, that's basically it. So I know this is a lot, but at least remember all of the names of the diseases, remember what they are, what happens, and the linking of the disease is very important. Like I told you, like maternal diabetes, for example, try to remember those links. And so yeah, that would be pretty good. All the best, guys. Bye.